My name is Leanne Larange, and I'm speaking to you today from Edmonton. I would like to begin today's session by acknowledging that Physiotherapy Alberta's offices are located on Treaty 6 territory, as well as the Métis Nation of Alberta's Region 4, which has been and continues to be the home of many Indigenous peoples since time immemorial. Physiotherapy Alberta recognizes that Indigenous peoples have been helping many to live healthy lives on this land since long before settlers arrived. And with that, we commit ourselves to helping move forward in their journey towards a good life, and doing so in a way that follows the spirit and intent of treaty, that of peace, friendship, and understanding. We recognize that people from across Alberta and beyond are joining us today, and we encourage you to take a few moments to learn more about the lands, peoples, and treaties with which you may be in relationship. This morning's presentation is the second in a series of 3 presentations regarding the current state of evidence-informed practice for physiotherapists. It takes the format of 3 mini presentations. So we'll begin with Eric Perrant speaking on the subject of when the bias is baked in. Eric Perrant is an associate professor in the Department of Physical Therapy at the University of Alberta with an adjunct appointment in the Department of Surgery at the University of Alberta. Our second presentation will be provided by Teri Slade on the subject of qualitative studies and assessing quality of qualitative studies. Teri Slade is a PhD candidate in the Faculty of Rehabilitation at the University of Alberta and research coordinator at the Rehabilitation Research Center at the University of Alberta. And then we will end off with a presentation titled "No One's Perfect, but How Flawed is Fatally Flawed," provided to us by Eric Perrant and joined by Doug Gross. Doug Gross is a professor in the Department of Physical Therapy at the University of Alberta. So with no further ado, I'll turn it over to Eric Perrant to start us off on when the bias is baked in.
Hello everyone, so it's a pleasure to be here to talk about when is the bias baked in. But before we talk about whether we have bias to consider, I would argue that we need to decide whether we're interested in the specific articles we're facing. So you have to decide which cake you're interested in. To do that, you're going to quickly read the abstract and sometimes some of the methods to choose which ones are most relevant to answer your clinical questions. So as you read your abstract and your bit of method to make that decision, you're going to ask where the patients assess similar to yours in terms of their severity, diagnoses, and other personal characteristics. You're going to check if the interventions that are studied are feasible to export to your setting, where they define clearly where you could replicate them. You're going to ask if the therapists involved are similar enough to you or whether you could train to achieve their level of expertise. And you're going to ask if the clinical settings are similar to yours in terms of the funding mode, the dose they deliver, the space and the equipment available, and whether patients need the same or more motivation. Finally, you have to check if the outcomes that were studied are similar to what you care about, and were they studied at the right time that you think it gives you the right clinical information. If none of those are true, then you may not want to proceed any further with your quality appraisal. You might just trash that paper and try to find a more relevant one. So once you find a relevant paper, now it's time to do the quality appraisal. Unfortunately, in our physical therapy world, and here I've reported kind of the summary of the PEDRO score quality for interventions on low back pain. We don't have a lot of excellent quality paper. In fact, our average is about 5.4 on a 10-point scale for the quality scores. And despite some improvement since 1955, we are kind of plateauing at a mean around 6 since then. So we still have a lot of issues with the research on physical therapy for low back pain. As we start thinking about what are the biases that affect our research, we find that in all PEDRO scored on the PEDRO database, we find that the most common issues are related to blinding. And of course, it's very difficult to blind participants and therapists and assessors to the physical therapy intervention. There's issues with concealing the randomization allocation. So what happens in our trials is that it's possible to predict as the trials are going on where the next patient's going to go sometimes. So that's a problem that could be easily fixed. We, of course, have some patients dropping out, so we're dealing with some missing data. And when there is missing data, there are statistical methods that could help account for that issue, but we rarely use the intent to treat analysis that could quantify how much of an impact this has. So those are our common issues. So as we do our critical appraisal, we should not demand perfection from clinical research because generally it's not possible. So what we're going to hope for when we do our appraisal is to look for studies that are good enough to inform our clinical decision making. So the warning I'm giving you right now is let's not throw the baby out with the bathwater as we do our critical appraisal. So as we do our critical appraisal, what we want is not destroying the paper, but what we want is to understand how much the bias is present and whether it impacts the results and their applicability to answer our clinical question. So let's dive in. How do we identify the common sources of bias in our intervention effectiveness study? So I've already talked about PEDRO, and if we want you to familiarize yourself more with how to apply the PEDRO scale, there's some good tutorial in text online or a training program that you can purchase to be improving your skills in that domain. Today I'm going to talk about the risk of bias assessment tool from the Cochrane collaboration. And another place where you could go for a training on this is the User's Guide to the Medical Literature, which have good online resources, presentations, and a book you can purchase. So this is still a short list of many existing instruments. Many of them overlap in the questions they're asking and the bias they're asking, so that's good for that. And then there's some nuances in terms of what they cover. Today I'm going to talk about detecting risk of bias in intervention effectiveness study. But if you do have another types of clinical question, please do search a little bit. There will be appraisal guides to help you decide if there's risk of bias in any of the other types of research you might be interested in. Because systematic reviews and meta-analyses are often going to be the first place you go for understanding if an intervention is effective, I provided here two options for you to appraise the quality of systematic reviews and meta-analyses. The OnStar 2 tools also has some training online, so I refer you to that website. And in the user's guides of the medical literature, you will find some training in appraising the quality of reviews and meta-analyses. But let's dive in. We are going to try to appraise the risk of bias, mostly in 5 domains as suggested in the Risk of Bias 2 tool from the Cochrane collaboration. We're going to look for bias related to randomization, to deviations from the intended intervention, to issues with missing outcomes, issues with the choice of how the outcomes are measured, and with the selection of the reported results by the authors in their publication. As we do that, for each domain, we're going to come with a judgment whether the study is at low risk of bias, some concerns, or high risk of bias. And ultimately, our opinion of the whole study should be based on the highest risk of bias we detected. So if a study had one domain where there was high risk of bias, that's likely going to be what influences our overall opinion of that study. So let's begin with each domain one at a time. First, we're going to talk about randomization. If the allocation of patients to one group or the other is done well, this should ensure that the groups have the same prognosis before the intervention, because it should balance the characteristics that we know or don't know that affects the changes in the outcome in each of the groups over time. To judge if randomization was done well, we're going to look for description of how did they generate the allocation sequence, so who would go where at what time. We're also going to look for information about how they were hiding whether the next patient would end up in one group or not. And we have to remember, despite it being hard to blind participants to what we do in physiotherapy, we can always conceal the allocation. So this should be an easy fix for our future trial. The issue that we're trying to prevent is as we allocate new participants to different groups, we should avoid that the authors or the trialists would be able to reject or choose a patient to go in a specific treatment group because that can influence the outcome. So we want to avoid that the authors can manipulate who enters the trial at a given time to control the intervention they receive. So example of what would be troublesome with randomizations are places where we would know the assignment rule. So when the description suggests that we alternated, we send one patient to one group and one patient next to the other group, that's alternating, and that becomes predictable. If it's allocation based on date of birth or date of admission, again, because the rules is set, and once we know the date of birth, we know which group the patient goes, that's an issue. Sometimes the allocation sequence is posted for everybody to see. So if you know where the last patient went, you're able to know where the next patient's going to go, and you're able to manipulate who enters the trial when to have your wish there. In meta-analyses, they've shown that when there's issues with the randomization and it becomes not concealed, it typically biases the results by leading to an overestimation of the effect of the new intervention by about 7 to 10%. So it's a notable issue. The other way we can detect if randomization has worked well is to assess the prognostic balance. And how we do that is by comparing the baseline descriptive characteristics in each group. I want to caution you, though, that we should not limit ourselves to statistical comparison of these characteristics between the group, because the studies were not planned to detect those differences statistically. So instead, we should look at the differences, and if there's a clinically important difference, in our opinion, we should dig in further and see how it impacts the results. So let's go over a small example here. If we have a study in older adults where we're comparing usual care to treatment with additional rehab to boost the recovery of walking distance. And in this trial, for some reason, we created a group for usual care that had a baseline age of mean 85, but in the other group, we had an age of 65. If we find that the first group gained 30 meters on their 6-minute walking distance and the second group gained 50, we might have difficulty deciding if this gain that's larger in the second group is due to the fact that they were younger to start with, or is due to the fact that they started with more rehab. So here, maybe they did try to have a good randomization, but it didn't work well to balance the characteristics, and it could still flag for us a risk of bias related to randomization. The next domain of risk of bias we're interested in is deviations from intended intervention. So did the patients receive the treatment that they were randomized to? Quite commonly, we will have some trials where some participants receive extra treatment that was not part of the trial protocol. Quite commonly, the control groups can seek additional treatment rather than stick with the usual care. We've had some exercise trial where the control group was supposed to be not receiving exercise, but they went in the community and found some exercise. So that's a problem. We also have an example where we did a stroke trial where we were trying to boost their walking ability. There was an intensive walking program and a not intensive walking program. But in order to come to the rehab center, the participants had to park far away. And for them, a walking distance from their parking to their therapy group was intensive walking therapy. And it turned out that this additional walking caused the bias, and the result, it reduced the difference between groups. The other issue is sometimes we allocate the patient to a group. They're supposed to receive an intervention, but somehow things fail and they don't receive the intervention as it was intended. Sometimes it could lead to more of the good treatment being offered, but sometimes it leads to less of that good treatment being offered. And so we have to pay attention to how it affects the result. Finally, commonly in physiotherapy, we have participants that do not fully adhere to the assigned intervention. So quite commonly we have low compliance on the prescription of exercise, for example, and that could affect the results. So from meta-analyses, we know that when patients don't receive their intended trial intervention, it tends to bias the results, and typically it increases the results. But in fact, as we saw, depending on what happened in terms of departure from the intended intervention, it could depend. So we have to read carefully what happened to really interpret what effect it has on the result. In this domain is also relevant to talk about the intention to treat effect and the per protocol effect. So we are going to be interested in a well-documented intention to treat effect when what we want to know is what is the effect for patients assigned to each group, regardless of whether they received the intervention and completed the follow-up. That's relevant for when we're trying to decide, should we introduce a new intervention in the health system? So that's when we're mostly interested in intention to treat effect. In the per protocol effect, what we're hoping to detect is what is the effect for the participants that complete the intervention as planned. We're asking, could it work if a single patient followed all our instruction? And so we might be interested in both, and these effects will differ when then some participants in the trial did not follow all the instructions and received the dose of treatment that we intended. So typically, the per protocol effect is larger than the intention to treat effect. So think about the reason that people drop out of trial are often related to the most severe patients having poorer outcome. They leave the trial. And so who's left in the trial typically has better results on average. And so that tends to lead to overestimate of the new treatment effect because we kind of lost the bad apples in the trial. So to help us decide if we're concerned about deviations from the intervention, we're going to try to figure out, were the participants and the therapist blinded? If they were not blinded, were they equally distributed between groups, the people that dropped out and did not complete the protocol as planned? And then if we managed to deliver the intervention successfully, did the patients stick to the protocol once they were assigned to a group, so that they had good compliance? And then if there was deviations that are reported, then we can still look for, did the authors account for that in their analysis or not? So all of that will help us decide if there's a risk of bias. So in putting this together, we're going to say there's a risk of bias due to deviation from the planned interventions. If the patients and the therapists were aware of the intervention, we detected some deviations or non-adherence from the protocol. These deviations, we understand, could have affected the outcomes, and they affected the groups differently. There was maybe more people dropping out in one group than the other. And the authors did not correct for those issues with their analysis, then we would be left concluding there's a risk of bias. The next domain of bias is missing outcome data, and there's many reasons why we might have missing data. We have people dropping out during follow-up, or not coming back for a specific evaluation visit, or maybe they attend the visits but they refuse to provide some data, or they are not able to do a specific test. Sometimes we lose the data, maybe a hard drive fails and we lose some data, and that affects the trial. And so the effect of this will depend on which data was lost and from which patient, kind of thing. So as we read the article, we have to try to figure out, is any data missing? To do that, typically we review what we call the participant flow. So typically it's a chart where it describes how many patients were approached and maybe who participated from that group and why not. That first part of the graph will help us decide, can we generalize these results to our practice? Next, we're going to follow up and look at, of the patients that were randomized to each of the two groups, how many were tested in each group, how many dropped out, and for what reason at different time points. And we're hoping to see, are these reasons balanced between the groups, and could they cause any issues in the result interpretation? Ultimately, we're going to conclude there's a risk of bias because of missing outcome if we detect there was some incomplete data in the trial, and the authors did not reassure us that this missing data did not cause trouble. And they can do that, typically, if they report analyses with and without the missing data, and they show that they're similar results, then it's reassuring for us. But if they don't, then we have still concern about that bias. Then, if the missingness could depend on the true value, so if we, for example, suspect that the patients dropping out are the most severe patients with the poorer outcome, that would be an example of missingness could depend on the true value. And then we have to assess, how likely is that it was missing due to the true value? And that would be based on detecting differences in the number of missing patients between groups, or the reason reported for missing are related to the severity of the patients, for example. That would be an example of issues. So as we interpret the relations between being missing and the status of the patient, we'll be able to judge if the bias leads to an over or an underestimation of the effect. The next domain is bias in the measurement of the outcome. And so here it will depend on whether the people we think have used the right outcome measurement method. If there's differences in how the outcomes are measured for the two groups, then that would also be a source of concern. We're going to try to determine who's the outcome assessors and whether they're blinded, because it would have an impact on some but not all the outcomes. Detecting mortality typically is not as much of a concern as results of a questionnaire in patients that are not blinded. Then we can ask, can the outcome measurements be influenced by knowing the intervention received? So again, it's the issue of some objective outcome are more robust compared to some subjective outcome, depending on the belief and whether judgment is involved in reaching the measurement decision. What we know is that in meta-analyses, when there's issues with how the outcomes are measured, typically it biases the results in favor of the experimental intervention, and it can have a pretty important effect. So this is one we should be alert to and keep track of when we read our papers. So our last domain is bias due to the selection of reported results. So that's an issue that will arise when the reported results is selected based on whether it favors a certain group or another one, or whether it has statistical significance or a larger effect compared to another outcome that was available to the trialist. So as we read the report, we might find that the people had access to many different measurements for a particular outcome domain, so maybe many pain tools, but they choose to report the pain tool, let's say VAS, that had the best effect. The other place we could detect that is reporting only a subset of the time points that were measured. So let's say outcomes are measured at baseline, right after the intervention, and at a one-year follow-up. It could be that the author only reported the significant effect right after the intervention, and they ignore the later follow-up because it wasn't significant. We could have a statistician choosing a specific analysis because it's more favorable to the intervention. Sometimes the statistician have choices of analyses they can do, and some could be adjusted for the confounder imbalance at baseline or not. And then if one is selected because it's more favorable to the intervention, it could be a problem. So as we see the reason and the specific outcomes reported and time points and analyses reported, we'll be able to judge how big an impact that might have on our results. So this is a brief example of an author that had measured depression using a modified scale and a regular scale, and they decided to report either the final values or the change values. They had two analyses options, and they also had measured anxiety in this trial. Now, when we read the results section, this author had decided to only report the depression change values because they were more favorable to the new intervention, and they had left the anxiety results out, and they had left the other method to measure depression. So there's a risk of bias in an example like that. So depending on how much you want to understand the risk of bias, you're going to look into different places. Most of what we talked about today is finding the information in the specific journal article that we're appraising. But nowadays, it's typically possible to find information in many different places. The trial protocols tend to be published on trial registry sites such as clinicaltrials.gov. And then if you were really hell-bent on assessing risk of bias, there could be many other places you can find the details. We don't necessarily expect you to go there, but sometimes you'll have more details if you dig. So as I said at the beginning, we don't want to throw the baby out with the bathwater, so not all bias suggests that the study as a whole is invalid. So you're going to have to try to understand, does the bias you detect, does it affect the whole study, or does it affect specific results? And as you understand each bias, you're going to be able to predict how does it affect the results. Is it favoring the experimental group or the comparator group? And how much of a bias is there? And if you can judge the effect, then you'll be better placed to judge the value of that study to answer your clinical questions. So keep that in mind as you try to decide. Yes, there's bias, but how bad is it, and how does that affect the result? So thank you for your attention. I encourage you to reach out if you have difficulty interpreting some bias. There's always things we can learn over time. I'll be happy to answer questions later.
Thank you very much, Eric. So now we move on to Chapter 5, Qualitative Studies, presented by Teri Slade.
All right, and and I'm Teri Slade, and today I'm going to be talking to you about quality and qualitative research. First, let's talk briefly about why we might choose to use qualitative research to inform our clinical practice. Evidence-based practice often focuses on quantitative research. If you had EDT courses in your physiotherapy training, chances are they focused primarily on quantitative research. This is partly because of the history of evidence-based medicine and the emphasis that quantitative research gets in that field, but it's also related to the specificity of questions that tend to be asked in quantitative research. Quantitative research asks narrow, specific questions and gives narrow, specific answers. So if you want to know how effective is a particular exercise program for osteoarthritis patients, you would look to quantitative research to tell you about that exercise program, what kind of outcomes it tends to achieve in a research design, and what sorts of patients that applies to. Qualitative research asks broad, complex questions and gives broad, complex answers. So if you are interested in why many of your osteoarthritis patients don't seem to want to do their exercises, that is something that you would definitely look to qualitative research to understand, because the factors that lead someone to decide whether or not to do their exercises or to prefer or not to do particular exercises, those are broad and complex questions. There are many factors that lead to those types of decisions. Qualitative research gives insight on the complexity of human experience. So there could be something about a person's life and their life experiences that affect whether or not they want to or are able to do their exercises at home. Qualitative research embraces the complexity of human experience. So while in quantitative research, we often have to control for a number of what might be described as extraneous variables, extra things that would affect testing of how effective a particular exercise program would be for the osteoarthritis patients, qualitative research embraces that complexity. The methods really have their strength in embracing that complexity. There have been many forms of quality criteria published over the years to describe quality and qualitative research. Those began in the 1970s and the 1980s, the most popular of which was probably Guban-Lincoln's 1985 quality criteria. They were adopted by many and are still cited by many today. If you had some training in qualitative research quality evaluation in your evidence-based practice training, then chances are you've seen Guban-Lincoln's quality criteria, possibly Cresswell's. Those were also quite popular. Or you would have seen a checklist or a set of standards. Those were developed starting in the 1990s and into the 2000s. Checklists are not without their problems, though. As I said, qualitative research really has its strength in the complexity that it brings into the research field and into clinical decision-making. And when we use checklists to evaluate qualitative research, we can often run into issues where a researcher or a reader believes that a paper is high quality just because you would be able to check off a number of boxes. But checking off boxes is quite a simplistic, narrow set of criteria. And in order to really evaluate qualitative criteria, we need to evaluate it with complexity, because that's really what it brings to the field of research. In today's presentation, my goal for you is to give you as little technical jargon as possible. This is not about teaching you to recognize a bunch of qualitative research jargon. It's not meant to make you an expert qualitative article reviewer by any means. It's more about helping you identify qualitative research that you can trust and that you can apply in clinical practice. So what do you look for when you're reading a qualitative research article to evaluate whether it's high quality or not? Well, the first thing that you'll hear, and this sort of thing shows up in a lot of quality criteria, is that the writing needs to be highly descriptive. You as a reader should be able to understand a lot of the context for what is happening, what is presented, how things happened in the research. You should understand how the analysis process went down. Oftentimes, journal articles, they have a word limit, and so sometimes the writing is not as descriptive as it could be. And so sometimes that is just a result of the word limits that the journals place. But all the same, you should, as a reader, understand a lot about the context for the participants, the context for interviews, if there were interviews conducted. There should be lots of quotations. The quotations are often the main source of data, and you want to see that data in the paper. Just as with a quantitative research paper, you would expect to see numbers to demonstrate what the data looked like. In qualitative research, you want to see that there are quotations and lots of context around those quotations. If you read a paper and you have no idea where these quotations are coming from, if they feel very cherry-picked or plucked out of a transcript, then that's a bit of a red flag. It's also really important to see counter examples. So within a section of a paper, you might have an argument that there is a particular theme around the phenomenon. You want to see quotations that support that, but also quotations from people that have had a different experience. You want to see that complexity. We know from clinical practice that our patients don't react the same to every single question, every single prompt, every single scenario, and we want to see that reflected in the way that the researchers did their work. The next thing we want to be looking for in a qualitative research article is that complexity. It's really the strength of qualitative research that it embraces complexity. And as a reader, you want to be understanding that complexity more as you're reading, not less. After reading a qualitative research article, you should feel that the phenomenon becomes bigger, not smaller, and the article should make you think more, not less. So for instance, if you have a patient who has chronic pain and wants to run a marathon, and you want to know what that experience is like and how best to support a marathon runner with chronic pain, in reading an article about runners with chronic pain, you should really come out of that article feeling like you have more to work with as a clinician, not less. You shouldn't come out with some checklist of all the things that you need to do for a runner with chronic pain in order to help them achieve their goal of running a marathon. You should come out of it feeling like you have an understanding of what factors are involved in that process of running or long distance running for someone with chronic pain. It should make you think more about the phenomenon, not give you simple answers that would make you think less. The next thing that we want to look for in qualitative research is evidence that the researcher follows the phenomenon. So in quantitative research, this might be seen as a bit of a weakness, but in qualitative research, it's really a strength. So in qualitative research, we really want to embrace the participants' experience, the contextual factors that are important to them. And when a researcher designs the study, for instance, the interview guide and the recruitment strategy, it's usually designed based on previous research or on the researcher's clinical experience. The research design isn't initially always based on what the participants have to say. So in qualitative research, it is a strength to see that the researcher started the research study, observed that in some of the data, maybe the first few interviews, that there were some questions that they weren't asking. Maybe there are things about the participants' experience that they hadn't considered, that wasn't in previous research or that they hadn't witnessed in clinical practice. And so we want to see that the interview guide changes a little bit. Maybe the research question changes a little bit. Maybe the types of participants they were looking for or their recruitment strategy changes during the research process. That's a strength in qualitative research. If you see something like a rigid, structured interview guide, that can be a bit of a red flag. If the interviewer is always asking the exact same questions in the exact same order, that's not allowing time for the participants to guide how the research is happening. It's not based on the participant's experience, it's based on a rigid set of questions that the researcher wanted to ask. In terms of clinical implications, you should intuitively feel that you have more information for clinical decision making, and the answers should not be simple. So for instance, if you are working in a pelvic pain clinic, and maybe you're working with a postpartum patient who is transgender, let's say you have a transgender man who is a postpartum patient in your clinic, and maybe that's the first male postpartum patient you've ever encountered in your clinic, you might look to qualitative research to understand better what factors are important to transgender men who are undergoing postpartum care. You would want to get the sense from reading a qualitative research study about trans men's experiences with postpartum care. You should intuitively feel that you have more information for clinical decision making. That research should not give you simple answers on exactly how to treat trans men in postpartum care. You should come out of reading that paper feeling like you have a little bit more information. You maybe have a better idea of how to create a safer space in your clinic. Maybe you have a better idea of what kinds of questions you could ask in order to create the best care possible for this patient. The last area that I'm going to be describing today is about ethics. So in qualitative research, ethics really goes beyond institutional review boards. There are many aspects of ethics that we want to see covered, but especially if you're reading research that engages vulnerable populations, you want to see some form of community engagement. So for instance, researchers who work with Indigenous populations will often have Indigenous researchers working on their team. Sometimes you'll see community advisors or community partners or some other form of consultation with the community in order for the researchers to really understand the perspectives of the community as they're designing the research and how they design the research in a way that it can benefit the community rather than taking that information from the community and bringing it into some ivory tower to benefit the researcher. We want to see that the research is going to benefit those vulnerable populations. If you see research that works with a vulnerable population but does not have any evidence of community engagement, that can be a bit of a red flag. We also want to see evidence that the researchers acknowledge that they affect the research. So the researchers make lots of decisions in designing research. This is the case in quantitative research as well. But ethically, in qualitative research, we want to see the researchers acknowledging this upfront. So it's very common to see in a methods section a description of who the researchers are, what their perspectives are. If they are a member of the community that is being researched, we want to see that described in that section. Sometimes it's called a positionality statement where the researchers describe who they are and what they believe and how that affects the researchers or how that affects the research. And sometimes we see it described as reflexivity, where the researchers describe how they affect the research. This is part of ethics in qualitative research, that the researchers know the ways in which they affect the research, and that can help you as a reader understand how the research was designed and how the researchers affected it. We also want to see that there's nothing identifiable in the data unless a participant wanted to be identified. So in qualitative research, our data is quotations from participants. Often that's the case. And so because we have interviews with participants where they sometimes refer to the clinic where they received treatment or who their physiotherapist is or who their partner is, maybe they describe their sister by name, we want to see all of those names and locations replaced with either pseudonyms or something generic like the term city instead of, say, Edmonton. The exception to this is when participants want to be identifiable, and this often happens when you have people who are advocates within their community. So I've seen people who are strong advocates within the transgender community, and they have been asked to be identifiable in the research. You might see this in injured workers advocacy. Sometimes you do see people who want to be identifiable in the research because their advocacy is important to them, and that's an exception to this nothing identifiable. Finally, I would encourage you to avoid what I'm going to call misery porn. You may find yourself in a situation where you want to read some research about a population that has experienced trauma, and this can be a very difficult thing to write about. But basically, we want to see that the research is going to benefit the population that has experienced this trauma. We don't want to see that the research is voyeuristic in any way. We don't want to get the impression that this trauma is being used to benefit the researcher's publication history. We want to see that the description of trauma is being used ultimately to benefit that population. So if you are reading research about trauma and it does not seem to benefit that population, I would describe that as misery porn, and I wouldn't consider that to be high quality qualitative research. Those are all the major areas of identifying quality and qualitative research that I'm going to discuss today. Here are some references that you can consult if you want to read more about the topic. And I want to thank you so much for your time, and I look forward to your questions.
Thank you very much, Teri. And now we'll move on to our final chapter in this morning's presentation, chapter number 6. No one's perfect, but how flawed is fatally flawed. Over to you, Doug and Eric.
Thank you, Leanne. I think this is a great topic. And my thoughts on this question have changed over the years, the more that I've been involved in clinical research. One of the main things that I've learned is that clinical research is hard, and it's impossible to do a perfect study. In healthcare and physical therapy specifically, we've really improved the quality of our research, but there are always flaws, even with the most carefully designed and conducted research. So the question of how flawed is fatally flawed is a great question. When do we know that we can just ignore a paper? One of the things that I've noticed is that as we learn more about critical appraisal and how to evaluate the quality of research papers, we often tend to become very critical, sometimes extremely critical. So I wanted to start this presentation with a quote from Sir Francis Bacon, also known as Lord Verulam. He's one of the early philosophers of science, one of the founders of the scientific method. He had this great quote that I love: "Read not to contradict and confute, nor to believe and take for granted, nor to find talk and discourse, but to weigh and consider." To me, that quote is saying that we need to find the proper balance between not dismissing everything as not good enough, not being overly critical, but also not believing or uncritically accepting everything that we read. We need to find the right balance and learn to read to learn within the context of everything else that we know. I believe that almost all research papers, even though imperfect, even though flawed in some way, all of them have something that we can use or learn from. Well, almost all of them. Some nugget of wisdom or practical advice. I also think that some of the largest problems with research come not from the methods, but from the interpretation of the results. And it's usually not from the study team, but from the broader community or the media or others. Studies often get overinterpreted and misapplied. Here's an example where a recent study was hailed and celebrated in the media as presenting a potential cure for arthritis, right? A huge breakthrough, Nobel Prize winning level discovery. But then you read a little further and you find out that this was a pilot study and it was done on rabbits, no humans were involved. That's a huge overinterpretation. And I think this happens way too frequently. With that being said, sometimes studies do have major problems with the methods, And I think there is a line that can be drawn as to what is too flawed. For me, the most significant problems or flaws come in situations of conflict of interest. People publishing research where they stand to benefit substantially from the results of that research. It's probably better if I demonstrate this through an example. So I want to talk about one study conducted on the effectiveness of vertebral axial decompression, like basically fancy traction, versus TENS for treating chronic low back pain. Here you can see the study title. It's basically a randomized controlled trial, so gold standard level evidence according to the title. It was done in Australia a few years back. You see the names of the researchers and their affiliations here. In this study, the results appear way too favorable to me. In this case, VAX-D had almost a 70% success rate, 68%, while the control group that received TENS had a 0% success rate. 0%. Absolutely no one got better in the TENS group. Not even placebo or natural history or anything else helped these people. 0% success rate. On top of those way too favorable results, we can see a potential conflict of interest. Now this is declared, and we can see that one of the authors is a shareholder in a private company that delivers VAX-D treatment. And that's good. Conflict of interest isn't always a big problem, and authors almost always have some potential benefit from publishing their results. But for me, the combination of this potential conflict of interest and results that seem way too favorable is a fatal flaw. When we look a little further, we see that the control group that received TENS was almost set up to fail, probably set up to fail. TENS was applied by a technician within the context of a VAX-D clinic. So those people receiving TENS would have seen other people around them receiving VAX-D while they had to lie around on their stomach for half an hour daily for 3 weeks, receiving nothing but TENS. This led to even more unrealistic results where all patients receiving VAX-D recorded at least some improvement, and that's what we typically see in research. Like at least some people get better regardless of what they receive, even if it's an inert therapy, right, because of the placebo or non-specific effects. But in this case, 13 out of 21 people receiving TENS actually experienced an increase in pain. So no one got better. 13 out of 21 had an increase in their pain. This all makes VAX-D look too good, and I just don't believe it. I judge this study, and others like it, to be fatally flawed. To conclude, in my mind, fatal flaws are rare in research papers. Most of the problems usually come from study misinterpretation or overinterpretation of results. But fatal flaws do occur, and we do need to keep our eyes open for this combination of a potential conflict of interest combined with unrealistic results in favor of the treatment that gave rise to that conflict of interest. I think that's a huge problem. It occurs rarely, but every now and again, you do see it in published research. So I'll stop there. Thank you, and I look forward to the discussion.
So hello again. Now, to continue our discussion of no one's perfect, how flawed is fatally flawed, I'm going to take it over and continue on a little bit. And now I'm going to start with my conclusion. So for how flawed is fatally flawed, I'll say beyond the rare major issues, we might never know, or it depends on what happens. And so I'm going to spend the rest of the discussion trying to flag a few additional major issues and expand on this idea. So beyond the issue of conflict of interest that Doug talked about, I want to introduce that there's surely a fatal flaw when we detect issues with fabrication or falsification of data in a trial. Fabrication is defined as somebody making up the results and recording and reporting them. Falsification, in fact, is manipulating the research materials, the equipment, the processes, or changing or omitting some data or results such that the research is not accurately represented in the research record. They're fudging the numbers. I would argue that there's possibly a fatal flaw in the context of plagiarism. So plagiarism is a misconduct of the investigator where they appropriate for themselves another person's idea, process, results, or words without giving appropriate credit to the other person. But for our purposes of answering a clinical question, I would argue that plagiarism is not necessarily an issue if the original material was still clinically useful. And we're going to revisit that later. Unfortunately, fabrication happens. So there's an example here of a top pain scientist, Dr. Scott Rubin, from the early 2000s. He was studying Vioxx and Celebrex, some painkillers. And it was found that he had faked data in one study as they did an audit and inspected the data. It was then found that up to 21, or I think it might be close to 24 now, of his studies had to be retracted because they presented evidence of fabrication of data. This fabrication had some important consequences. When they reviewed if we pulled the data from Dr. Rubin from existing reviews, they found that 1 of 6 reviews having used those studies would have come to a different conclusion after we eliminated the fabricated data. It's also had consequences on everything else that this author published, because it was found that 13 of his papers could not be retracted after investigation. They couldn't find reasons for misconduct. But for the readers of these papers, knowing that Dr. Rubin has done fabrication elsewhere, there's still doubts in interpreting those papers. So it does affect lots of clinical research out there. So how can you detect that kind of fatal flaw? So one option we have is to look for retraction notices. Those oftentimes appear in the journal, but the problem with that is they oftentimes get published multiple issues or sometimes multiple years after the original paper was published. You can also look for retraction notice in Retraction Watch database. So it's a place where you can search by authors or by subjects whether there's been retraction on certain topics. And in the literature databases, such as in PubMed, you will find a note that a paper has been retracted. So the citation would still be there, but there'd be a note that the paper has been retracted. Unfortunately, a lot of the papers that have been retracted are still cited multiple years after there was a retraction, because the other people citing them don't necessarily know that their paper had been retracted at the time they're citing them. So we have to be alert. So if you go in PubMed, you open the reference for an article, there would be a big flag suggesting there's been a retraction of this article, and then you can track the reference to the citation notice. So then you'll find there's been a little letter to the editor or a little comment published somewhere explaining why the paper was retracted, and that's how you can decide whether the paper is valuable or not. The other issue we were talking about was plagiarism of an article. So here's an example where a review was published and it was later found by the editor that this paper had to be retracted because it was a near identical copy of a previously published paper, and that had been missed during the review process. So the information in that paper might still be good, and we would have to appraise the original to find out. But in this case, the authors have done misconduct and plagiarized some work. From a journal editor point of view, they're hoping to catch many of those fatal flaws during the review process before the papers get published. And so one of the editors has published kind of a list of common reasons why they throw out a paper during the review process. Often it's because the idea is judged not important and does not contribute to science, or the work is not original. It's already been done, well done, and they don't pursue it further. Sometimes the authors did not test their hypothesis properly with their design, or they should have used another design because there was no justification to take a design that was less than optimal. Sometimes they did the trial with too few sample cases, and that's an issue. Sometimes during the conduct of the protocol, too many things happen that force departure from the protocol that it's hard to interpret, and therefore it's not published. Quite often they don't choose the right control group, or they conduct statistical analyses that are not appropriate for the data they have. Quite commonly at that stage, they'll also reject paper where maybe they presented the results logically, they found some good results, but they conclude things that have nothing to do with what they found, and so that's a major issue. Doug talked about the conflict of interest, and if the paper is so unclear that it's hard to judge its value, it will also not pass the screening of the editor. So when I said it depends, there's also a number of fatal flaws that could occur, that could possibly be fatal, but not necessarily. So the study could have been done with unethical research methods. Sometimes the conclusion might still be clinically relevant, but the authors would have done misconduct in conducting unethical research, so we have to be careful. Doug talked about conflict of interest. I also mentioned that if the study is irrelevant to your clinical question, it's a fatal flaw to answer that clinical question from your perspective, and I would dismiss that paper. And we talked about appraising bias in our first presentation, so if the study is judged to really overestimate the effects, underestimate the effects, or it's so unclear that you really don't know, then it would be a fatal flaw for the purpose of answering your clinical question, in my opinion. I would caution you again, though, that as newly trained clinical appraisal, we tend to be very critical, but we have to be careful not to throw the baby out with the bathwater. So when I said it depends based on the quality appraisal, again, you can try to assess the overall risk of bias for a specific result, and remembering that the least favorable risk of bias assessment across different domains would be the one that would influence your decision. We have to remember most papers are kind of so-so, but there will be some deserving gold star and some that will be so bad that they will constitute a fatal flaw that they have such a high risk of bias. I'll throw in a note as well that quality of reporting is not the same as quality of the study method. However, both of them might limit your confidence in the reported results, because if the reporting is unclear, you may not be able to tell if it's valuable to you or not. So as you decide whether there's a fatal flaw, continue assessing the relevance of the paper to your clinical question, and we talked about how to do that. Continue assessing the research quality in terms of the risk of bias, and you'll need a bit of both. You'll need it to be relevant and free enough of risk of bias that you find value in the paper. So in closing, we have described some major fatal flaws, which luckily are fairly rarely published, but now you're aware of them and you know how to detect them. We've also talked about the fact that there could be some fatal flaws depending on your quality appraisal and relevance appraisal, and you would want to only focus your attention on the papers at the sufficiently low risk of bias and relevance to your clinical questions.
Okay, so I'd like to thank everyone who attended this morning. We're going to turn it over to a Q&A session. So there wasn't much in the Q&A that we had through the chat box. So if anyone has a question that they would like to throw, we'll open the floor to our three speakers who are also ready to go. Okay, I've got a question, so I'll kind of jump into the queue. So we'll start off actually with our first speaker, Eric. You spoke to risk of bias in randomized control trials. What do we need to keep in mind about risk of bias when looking at systematic reviews? For example, when you combine trials with different types of risks or different risk severity, along the same lines, like what should physios keep in mind when it comes to combining studies of different qualities in a systematic review?
Thank you. Yeah, so with systematic review, I would say there's the issue of quality that could put more weight on bad studies. Sometimes this is handled by the reviewers by weighting their estimates. So either they will only keep the papers that met a certain quality threshold in their final recommendation summaries, and so that would be reassuring that the conclusions are based on best evidence. Or sometimes they will, in a meta-analysis, for example, they'll put more weight to the studies that were judged to be of good quality when estimating the final effects. So when that happens, then that's reassuring. Otherwise, you hope that most systematic review will present you with a summary of their quality appraisal separate from their conclusion. And so you can kind of track down in the tables which results are mostly represented. Another thing to watch for, I would caution, is with the systematic review sometimes is how the search was done and trying to trust, did they capture all the evidence on the topic, or could there be cherry picking into what's been included in the study? So it's not always easy to judge, but if you review the search strategy, then you can know how good of an effort the authors have done in tracking down the best quality and the most relevant evidence to your question.
Thanks, Eric. Does anyone else want to jump in on that one?
Not really. I do have a question for Eric, though, if that's okay.
Yeah, absolutely.
Eric, you talked about blinding, and that's an issue both in the randomized controlled trials as well as the systematic reviews when we appraise those trials. But it's just so difficult to do in rehab and in physical therapy with many of the interventions that we have. So I'm just wondering about this issue of blinding, and given that just about every physiotherapy trial gets rated as poorly done, is it something that we kind of need to reconsider, and should we give it as much emphasis?
That's a good question. I would argue that there are some outcomes where it is possible for us to hire another evaluator that wasn't involved in the treatment. And so if it's not a pragmatic trial, one that would be done directly in a university setting, it might be possible to blind the evaluators. For a lot of our questionnaire-based material, it's just not feasible. The patients know what they're receiving. And then I would agree with you that maybe what we need to do then is just be careful with the interpretation. So we know there's a tendency to overestimate when patients are not blinded. And so if the effects of the results are just kind of moderate, and we know the patients knew what they were getting, and we understand their beliefs about what experiment would have worked better for them, then we can put that as a moderator in when we interpret the results, would be my suggestion. I turn the question back to you. Any thoughts?
Well, I was thinking maybe we do need to spend more time exploring both the expectations of recovery from a given treatment on the part of the participants in the trials, but also the therapists. How confident are they that this intervention that they're not blinded from will have an effect? And maybe we could do better controlling for that in our analyses.
Yeah, I agree.
Okay, we've got a question from Lisa. She was wondering, how do we know what the authors are not reporting? Is that an issue within research, and is that something that you guys have a thought on?
So I can tackle that one. So Lisa, I'd say there will be some that are more obvious. So when you read the methods of the journal and they describe that they use a list of tools, and if you know those tools, you know what kind of results these questionnaires produce, you know what kind of results these measurements would produce for different movement. And then when you read the results section, they might only report statistically significant findings and leave out a number of things they had said they were measuring. So that would be an easy one to detect, and it happens. So that would be the first example. For people doing systematic review, then our job is a little bit harder, where we would read the paper for what they reported, but we would also track down the registered information on a clinical trial registry, or try to get our hand on the original protocol for that study. Sometimes you can get that from the funder. It's hard for a busy clinician to do that, but then you can see if there's a discrepancy between what's reported and what was planned. The other thing, sometimes in the methods, you'll see there was measures taken at baseline, right after the treatment, and at a long-term follow-up. But then when you read the results section, they only present the results right after the treatment when the effects were largest, and they ignore the rest. So that could also be an example of things that were not reported and could leave some question marks in your mind.
All right. Anybody else want to weigh in on that one?
Well, I agree with Eric. I think that every journal, almost every journal now, requires a pre-registration of a protocol or the study proposal. And so one of the best ways is to go back to that published protocol to find out what they said they were going to do, and then compare it to what they are reporting. That's one of the only ways that you can see if they're selectively reporting only positive results. Otherwise, it's tough. That's a good question, and it is hard to find out what people are not writing up and reporting.
Yeah, I
Okay.
agree with that.
Perfect. So Teri, this question is kind of heading towards you. One of the things that Leanne and I kind of talked about, taking away from your talk is that while fidelity to the study plan is critical for quality of the quantitative study, but somewhat the converse is true with qualitative, in that in qualitative studies need to change as the study progresses. Is that a fair summary statement?
Mm-hmm. Yeah, well, I think one of the things to consider is, if we look at the evidence-based practice pyramid, like levels of evidence, and qualitative research is typically at the bottom. And if we think about qualitative as kind of laying a foundation for research that might come after it, or laying a foundation for decisions that you make in the clinic, a lot of times the questions that you're asking are really quite novel, and they're so based on people's experiences, which change based on how society changes. And so a qualitative study done 20 years ago may not resemble what the results look like today if you replicate it precisely, even with the same researchers and the same people, because society changes over that time. And so you expect that the researchers are following, you want the researchers to follow what the phenomena is. And with quantitative research, of course, you don't want that to be the case. You want to be able to control for a number of variables, plan things out ahead of time, and carry out what you plan to do. And this is why trial registration is such an important thing in clinical trials. But in qualitative research, yeah, it really is evidence of rigor that people will follow what the participants have to say, because you're laying that foundation, asking broad questions, and you assume that previous research may not be able to inform the current research in the way that it can in quantitative research.
Excellent. Okay, I have one last question, then we're going to wrap this up. So I think kind of, Doug, we'll put this one to you, but the other two can kind of jump in. How much would we have to dig for conflict of interest? Like, is this must that they disclose any conflicts of interest? Is there standards that exist in publishing research that the publication itself would take on in order to identify that? Or is there an academic standards for what is or not is, or what is not considered a conflict of interest?
That's an excellent question. It's a tough one to answer. I would say that the standards have changed over the last few years. If you're looking at an older study, say published 15 or 20 years ago, they may not have been required to disclose if they are a shareholder in a company, if they're receiving payment from a device manufacturer or something like that. But nowadays, when we publish articles, there are typically pages and pages of disclosure statements that we report. We report on every grant, we report on every honorarium, every reimbursement for traveling to a conference. So I think the standards are much improved and way better now. And usually every paper will have a statement that summarizes that briefly. What are the relevant conflict of interest for each individual author on the paper?
Is it just financial conflict of interest that, I know conflict of interest exists in many different kind of planes. So for researchers, is financially kind of the major COI that we look at, or is there other kind of things that are taken into account?
Well, I think financial are the biggest. Beyond that, you have to look at the institution that they're affiliated with, right? I guess the question is, do they have anything to gain from being involved in the study and from the results that were found in the paper, right? So you do look at the institutional affiliation. Are they coming from a university? Are they coming from another rehabilitation type group, a professional association, whatever it may be? So it is bigger than financial, but I think the money is really key.
If I can jump in on that one, I'd say for us with physiotherapy, where we don't necessarily profit from drugs or devices as much, sometimes there's notoriety or fame that could come with pushing our new questionnaire, or our new tool, or our new treatment protocol. So if there's an issue of maybe a brand behind a protocol or a fame for a guru teacher kind of thing, that might be something to watch for.
Okay. All right. So if that's it.
Can I ask one question of Teri?
Yeah, absolutely, Doug. Go ahead.
So Teri, you talked about these checklists for appraising qualitative research, and those have always kind of felt funny to me. I felt a little bit uncomfortable with those. I mean, it's almost like it's applying a quantitative perspective with these checklists. And did you do all the right steps to control bias and so on? Anyway, it's like applying a quantitative approach to appraise quality of a qualitative research. I'm just wondering if you could talk a little bit more about that. What are your thoughts on these checklists that are available?
Yeah, I mean, there are a few checklists that are used quite widely. I think when you're a researcher trying to get your research published, and I've encountered this a couple of times, where a journal will have a particular checklist for qualitative research that they adhere to. And, maybe you have reported things that would fulfill a different checklist, but this checklist, requires a certain number of things that maybe are not related all that much to qualitative rigor, but would make sense to, say, a quantitative researcher reading that article. And I've often had to kind of go back and put in additional information related to or remove information in order to get the word count short enough to fit in things that are asked for by the checklist. And the thing that always concerns me about that is that there are likely researchers out there that feel like if they can check off all of those checklists and get published in this particular journal, then that means that they've done a good job of the qualitative research that they've conducted. And being able to check off those questions, say yes to all these questions on a checklist, doesn't mean that the research was well done. You can have something that exploits a vulnerable population, and it can still fulfill the requirements of a particular population. You can have something that gives, all the required amounts of context in terms of what the checklist requires, but doesn't give the context of how the research changed and evolved across the duration of the data collection and the analysis. And, for some studies that's not problematic, but, if you start reading qualitative research, and honestly, most people, when they start thinking about qualitative research in the context of the complexity that it brings to clinical decision making, they read qualitative research. The more you read of it, the more you become accustomed to, this was a gap that, wasn't fulfilled for me, and I feel like I didn't have enough information on this. Or, maybe you're reading something and it feels like the researchers are really strict protocol that didn't change across the duration of the study, and that might give you pause to question how it was conducted and whether it was actually authentic to the participants' experiences or kept in this strict protocol because of what the researchers wanted. And that doesn't mean that, again, you don't, as Eric was saying, you don't throw the baby out with the bathwater. You can probably learn something from that, but it doesn't mean that you're getting the most rigorous qualitative research that you can. And applying that quantitative lens to qualitative research doesn't equip you to really get that rich context that can help you understand people's experiences in a way that will help you make decisions.
Okay, good. Thank you very much. So being mindful of the time, we're just going to wrap this up. I'd like to once again thank Eric, Doug, and Teri for their work presenting today. It was excellent, and I'd like to thank the audience for attending. Just a reminder that, as usual, the presentation will be posted in 2 days' time, along with handouts from the speakers. And then lastly, I would just like to remind you of our next presentation, Professionalism in the Era of Social Media, with Jason Culley, who is a partner at Field Law. This webinar will be March 17th. It will be hosted at noon instead of our usual 8 a.m. time slot. Part 3 of this wonderful series will be coming in May, so stay tuned for that. Thanks again for joining us today, and we will end this podcast or this webinar. Thank you.